Welcome everyone. I would like to present my 3-month progress report in my PhD topic, which is investigation of intensive care procedures, prognostic and mortality factors in resuscitated patients. My name is Boldizsár. I'm a second-year resident and PhD student in Heart and Vascular Centre. My supervisor is Andres Ima. My scientific methodology supervisor is Rita Nagy. My vision is the best medical knowledge and practice needs constant update by scientific research. My mission is personal involvement in acute cardiac care, and my focus is to develop and refine intensive care strategies for resuscitated patients. We have 3 projects. 2 of them is meta-analysis, which is still ongoing, and we're planning to start a randomized controlled trial in the next year. Let's talk about the first project, the investigation of neurological prediction scores in out-of-hospital cardiac arrest. This is a systematic review and meta-analysis. My co-investigator is Henriette Mészáros. The incidence of out-of-hospital cardiac arrest is between 70 and 170 per 100,000 inhabitants in Europe. Despite advantages in resuscitation, the improvement of intensive care techniques, the survival rates at hospital discharge remain very low, on average 8%. This study could clarify the question which score is the best for estimating neurological outcome after successful resuscitation. Why this is so relevant to our clinical practice? I think it is a very easy and very important question, because using this prognostic score system in the ICU can prevent the healthcare system to apply costly and intensive resources in cases of futility. Our clinical question is which is the most accurate and reliable neurological prediction score system in out-of-hospital cardiac arrest cases after resuscitation. Our population is successfully resuscitated out-of-hospital cardiac arrest patients. The intervention and the C group is all prediction score system which was used the neurological prediction in the literature for resuscitated patients, and the outcome, the main outcome, is the good and the bad, the good and poor neurological outcome, which was defined easily by CPC score. The clinical implication of the topic would be a mindful allocation of intensive care resources. We made our systematic research search 8th of November. With this search key you can see below. You can see in the slide the flow chart of the selection. We made the duplication removal, and because of my cause in November and because of the lot of hits, the selection process still ongoing and will be finished in the next week. Let's talk about my second project, the prophylactic versus clinically driven antibiotics after successful resuscitation, which is a systematic review and meta-analysis as well. My co-investigator is Boglárka Veres. Shortly about the background. The early onset pneumonia is a frequent infectious complication after resuscitation due to potential aspiration, micro and macro aspiration, during the resuscitation and the airway management, and the immunological impairment after resuscitation. There are only few data whether early timing of antibiotics could efficiently reduce the risk of pneumonia or any other infectious complication during the ICU treating. Our aim is to compare the effect of prophylactic antibiotics compared with clinically driven antibiotics on infectious-related outcomes. Our clinical question is, does prophylactic antibiotics decrease the rate of mortality and the incidence of pneumonia compared to clinically driven antibiotics? The population is successfully resuscitated patients. The intervention group is prophylactic given antibiotics. The comparator is clinically driven or some proven infection-driven antibiotics, and the outcomes It's the 28-day mortality, the duration of ventilation, the incidence of early and late ventilation-associated pneumonia. Our hypothesis is prophylactic antibiotics is superior to clinically driven antibiotics. And the clinical implication of the topic could be decrease in mortality or incidence of early onset pneumonia and any other infectious complication. We made our systematic search in 5 databases. The search key you can see below, and we will start the selection in the next few days. During the preliminary search, we found only 3 RCTs in the second project. One of them, there was 200 inhabitants, and one of them was 60, and one of them 27. So there are very low good data in this topic. So it is clear. It was clear for us to start a randomized control trial as a third project in the future in the same topic, and give more data and give and one more RCT to a meta-analysis in the future. So about the RCT, we would like to cooperate with the Department of Anesthesiology and Intensive Therapy, especially with Zsolt Molnár and Zsolt Iványi. We would like to discuss in this topic, and we would like to do together the protocol drafting. There is an overview about my topics. I would like to thank you for your attention, and then I would like to say some quote, as do before, from Lady Galadriel from the Lord of the Ring trilogy. Even the smallest person can change the course of the future. Thank you.
Congratulations, fantastic project that you have here. Sorry, I did not catch the details with the third project. So you plan to do the randomized trial because there is a lack of trials in the literature?
Yes.
Yes, but there are actually trials.
There are only 3 RCTs.
Three RCTs that you can use in your meta-analysis, your second meta-analysis, I understand. But you also have 3 anyway. What will be the differences? Or what do you plan, or what, or actually you simply need more evidence with the same structure or the same methods that they used?
I think we would like to use the same methods because there are one RCT which is made with very large amount of inhibitants, and the other 2 is not really good for us. So it not give any relevant information about using prophylactic antibiotics or not using.
And did they find actually that this is useful? Those 3 articles?
There was neutral. There was
no differences.
No differences.
Okay.
Sorry, there was no difference in the incidence of pneumonia and the mortality of the groups.
I understand, but still, probably you should check if there actually probably the statistical difference is one thing, but also if probably you can save 5% out of 100, and without being statistically significant, even that can be useful for those 5 patients at the ICU, I think. But thank you for your answers.
Thank you.
Can we go to your first PICO, please?
Yes, I mean, we see on the next slide that you actually have a huge amount of papers, of the one after this. So you are before selection, if I understand that. So this project is a little behind. So now we can go to the PICO. I mean, there are many parameters. So did you do any kind of preliminary kind of, I would say that guessing or hypothesis that were, I mean, because this is very general, mindful allocation of intensive care resources. I feel that, I mean, all the other ones which we saw, I mean, was very direct. I mean, just focusing on certain things. And this is some kind of networking. I mean, lots of, I would say, that questions or biomarkers what you want to study together. So is there a clear view that what do you do in the next step?
Sorry, I didn't have clearly the question. Can you repeat?
Maybe just, I would just say that you have to speed up with your project.
Okay, I will.
Of course, with the help of the SMSs and maybe with the statisticians too, so you don't do things which are undoable. I mean, I see the danger here and seeing just not that well structured as the others.
I would like to ask that what guidelines do you use in your hospital in cases of successfully resuscitated patients? Do you have your own guidelines or international guidelines?
We have the international guideline which was updated in 2021, and we have our guideline in Heart and Vascular Centre accords to the updated guideline.